Excellent. All right. So thank you to all of us who are joining us streaming. I'm sorry that we're starting 10 minutes late. We just had some audio difficulties, but everything seems to be back on track. Tonight we're going to be talking about attention deficit hyperactivity disorder, or ADHD. All right, is this a neurological or a psychological disorder? That's one of the questions that we're going to try and answer tonight. We're going to open this up to questions. If you guys want to send your questions through as we're going along, I'm happy to stop and answer them as we're going through. Dr. Wright will be kind of monitoring the chat, and I'll monitor the chat a little bit as well. But anyway, let's get things started. So, attention deficit hyperactivity disorder, or ADHD, neurological or psychological disorder. Clicker's not working. Here we go. Our topics for this talk: what is ADHD? How is ADHD typically diagnosed? How is ADHD typically treated? Yes, there is treatment in addition to medication, and how GCNC, how we here bring new hope. We're going to talk through some patient stories as well as we go, and then we'll have time for questions. So it's a pretty similar format to the talks that we've given in the past, especially myself. And I apologize, I kind of jumped right in here. My name is Dr. Frank Patterson. I'm one of the staff clinicians here at Georgia Chiropractic Neurology Center. We have 7 clinicians on staff, so I'm one of those 7. Very lucky to be here. But let's jump in. What is ADHD? Children with ADHD may have trouble paying attention, controlling impulsive behaviors, and may act without thinking about what the result will be, or be overly active. One of the most common neurodevelopmental disorders of childhood. And it's usually first diagnosed in childhood, but it often lasts into adulthood. And there's a little bit of controversy with that. At one time it was thought that adults don't have ADHD, but it's become more accepted that this can persist beyond childhood. And I do want to take a step back. I introduced myself, but there are a few people that I wanted to thank regarding this presentation. I wanted to thank Dr. Ellis as always, because I got to see some of my first ADHD patients. Some of the first kids I got to meet that were living with ADHD was when I was an intern with him, and I've learned a lot from him over the years. Dr. Jim Duffy, who I used to work with, who was my mentor for many years, he's since retired, but I learned a lot from Dr. Duffy as far as working with kids in general, and especially with ADHD, and also Matthew Worth, Dr. Matthew Worth, from the Carrick Institute. He's got a booming practice in St. Louis, and he works a lot with children, and I took his course at Carrick Institute on neurodevelopmental disorders, which ADHD fits underneath that umbrella, and it was just a tremendous learning experience for me. So thank you, Dr. Worth, as well. But let's pick up where we left off. So I think everybody's fairly familiar with ADHD. It's a pretty common neurodevelopmental disorder. It's a pretty common issue that a lot of children are living with these days. An estimated 7 million, or 11.4% U.S. children aged 3 to 17 years old have ever been diagnosed with ADHD. So we got to keep in mind that have ever been diagnosed with ADHD. So that's meant to be cumulative. And this is according to a national survey of parents using data for 2022. A lot of my presentation, not all of my presentation, but especially when it comes to statistics, a lot of it came from the CDC. So we're using CDC data here. In 2022, an initial 1 million U.S. children aged 3 to 17 years old had ever received an ADHD diagnosis compared to 2016. So an additional 1 million. So that's a lot in a very short period of time. And as with some other neurodevelopmental disorders, there's the concern as to why this seems to be more and more prevalent. Is this that we've got better diagnostic and more accurate diagnostic criteria to diagnose children, and now, like I said, adults with ADHD? Is it that it's happening more, right? Are we diagnosing it more, or is it happening more? I think it's probably a combination of both. I think there's a lot of factors that could lead to an ADHD diagnosis, and we're going to get into that tonight. Boys, 15% were more likely than girls to be diagnosed with ADHD, right, at 8%. So it's more common to see a boy with ADHD than a girl, but that does not mean, that it's male exclusive. And according to a national 2022 parent survey, nearly 78% of children with ADHD had at least one other co-occurring condition. This has a lot of significance, hence why I highlighted it. And some of these other co-occurring conditions are in the graphic that I have next to these statistics, right? And this is important because you could be living on the autism spectrum and also have an ADHD diagnosis. You could have learning disabilities and have an ADHD diagnosis, right? It's very common to have ADHD and something else, right? There's tic syndrome that's on there, mood disorders, substance use disorders, intellectual disability, anxiety disorders, impulse control, personality disorders, and sleep disorders, and honestly, many, many more. There's a lot of crossover between this and sensory processing disorder. Sensory processing disorder is something that I'd definitely like to do a talk on at some point as well. But there can be a lot of crossover between ADHD and sensory processing disorder, and trying to figure out which one do you have, or do you have a combination of both, right? Because 78% of children with ADHD had at least one other co-occurring condition, right? So then you got to ask yourself, what does it really mean then to have ADHD if it's so common to have it with something else? And we're going to kind of dive into that today. So how is ADHD typically diagnosed? So this is kind of the Bible as far as diagnosing ADHD. This is the Diagnostic and Statistical Manual of Mental Disorders, the graphic that you see on here. We're currently on the 5th edition, but it was revised in, I believe, 2022. And if you can see at the bottom, it's a little tough to see because the graphic may be small on your screen, but it's published by the American Psychiatric Association, hence the subtitle of my talk tonight. Is it a psychiatric issue? Is it a neurological issue? I would argue that it's both. And honestly, the American Psychiatric Association would argue and have argued that it's both. They put it under the category of a neurodevelopmental disorder, right? So there's neurological aspects to this as well. They don't really get into the nitty-gritty of that to a certain extent in the DSM-5, even in the updated version that we're on currently. But if you look at research, that's where, if you look at research articles, that's where it's going to dive into the neurological aspects of it. There is some controversy. Some people feel like it's more psychologically based. It's common to see it in certain populations. It's more common in children that have had some kind of life trauma event. It's more common in children that have gone through like the foster care and adoption system. So some people feel like there's at least a strong psychological component, if not more purely psychological and neurological. And I would argue that there may be varying presentations of it. And we're going to get into how it is diagnosed right now, and I think you'll start to understand why there's so many gray areas. Because at the end of the day, there is no single test to diagnose ADHD, right? It's not like a strep test. Like, do I have strep throat? Let's scour the back of your throat with a Q-tip. Let's send it off to the lab and let's find out, can we grow a streptococcus culture? And then we know that you have strep throat. Granted, there's a lot of issues that people deal with. Concussion. There is a major thrust with concussion to try and figure out, a single test or what's called a biomarker, something that we can find in a lab test or a blood test to say, hey, you've had a concussion. Well, it's the same thing with ADHD. There is no like biological biomarker. There is no specific thing that you're going to see on imaging within regards to the neurology. You're not going to see it on an MRI or even necessarily an fMRI. There is also SPECT scans where Dr. Daniel Amen has been a pioneer in looking at this, looking at the neurological aspects of what are traditionally considered to be psychiatric diagnoses, and certainly ADHD falls under there. And Dr. Amen, with the SPECT scans that he's done, has found different patterns associated with the SPECT scan, and one of those patterns happens to be ADHD. That's the closest, I'd argue, that I've seen, that I'm aware of, right? As far as he may see a presentation in the imaging that he's done with a SPECT scan. And with a SPECT scan, I should probably take a step back and explain what it is. But a SPECT scan is kind of it's a 3D representation of the brain. Okay, the way the imaging is taken is you're injected with a radioactive dye that's attached to glucose, and then based upon glucose usage, which is essentially fuel for your brain and your body, it looks at how much glucose usage there are in different areas of the brain. And then it compares it to some kind of normative data, right? Some standardized data. And there can be issues with standardized data. And what's normal for one person may not be normal for another, but you can see general trends. So you could see overactive, arguably, or underactive areas of the brain based upon a lot of glucose usage, extra glucose usage for overactive, and less glucose usage for underactive. But that's the closest thing that we have to some kind of imaging or some kind of biomarker that can establish whether ADHD is on the table or not. But fortunately or unfortunately, I would say mostly unfortunately, there's a lot of controversy with SPECT scans and how Dr. Amen is using them. I think that they can be extremely valuable, but other people are still yet to be convinced. So let's talk about diagnosing ADHD. More typically, you're looking at a checklist for ratings of ADHD symptoms. This is how it's traditionally done. If your child is suspected to have ADHD and your school system is going to supply the testing for it, or you take them to a licensed therapist that does specific testing for ADHD, you're going to be looking at primarily a checklist system. Checklist system. So with the checklist, it's basically, are you observing these certain things? And they may have a checklist that that therapist will check boxes for as far as therapies that they observe in their office. And then they may have a checklist for the parent and wanting to know what the parent observes. And then they may have a checklist that involves a teacher so that you can observe the child in 3 different environments. At, say, like a therapist's office, at home, and then in the classroom. Because you want to see if these behaviors persist across these 3 different environments. Because if it's pretty persistent across these 3 different environments, then it's more likely that it's ADHD. Now, there's also some more specific questionnaires, and these are some of the ones that are more typically used. So the National Institute for Children's Health Quality, Vanderbilt Assessment Scale, the Connors Comprehensive Behavior Rating Scale, the Child Behavior Checklist, and the Swanson, Nolan, and Pelham 4th questionnaire. So these are some standardized questionnaires to get that diagnosis. One of the things that we need to ask ourselves as we're talking about how ADHD is typically diagnosed is, like, do you want this diagnosis in the first place? One of the things that we experience with parents that come in, sometimes they're like, yes, my child has ADHD, they've been formally diagnosed. Sometimes we get requests where parents are seeking a diagnosis. And then some parents are like, hey, I suspect this, but I don't want this label for my child. And I totally understand where parents would not want a label for their child. They don't want them put in this box where then, if a child has a label, then they may feel internally like they have some kind of limitation because they have this diagnosis, right? Whereas, if we don't attach a label to it, there's some psychiatric aspects that can arise if you have that label, right? There's some feelings that you may have about it. You may get down on yourself at times when it's, different people have different conditions and can live full lives, but sometimes a kid might be down and be like, well, I just have ADHD and that's how it is, which is, obviously not true, right? But you may have those feelings. So some parents don't want this diagnosis. And I respect parents whether they want the diagnosis or not. The only time that I do encourage parents to get a diagnosis, right, where I might be like, hey, you really want to consider this, is if it can be a factor in schooling, right? You might have an IEP that you want for your child, an individualized education plan, and for a school system to be able to provide that, it's way more likely that they're going to be able to provide you an IEP if there's a diagnosis that your child has that could necessitate an individual education plan. Sometimes it's not provided unless the child has a diagnosis. I'm not saying that's right, but that's pretty much how it works. So if you're a parent and you want accommodations for your child, you're probably going to need a diagnosis, right? And it's probably going to be helpful for you. That may get them more individualized attention in the classroom. That may get them more time on testing. That may open up the opportunity for your child to get up and move around a little bit more in the classroom than the other children, because movement can calm their brain down and can help them focus, right? There's reasons to get the diagnosis. Like I said, I respect a parent's right to want to have the diagnosis or to just do whatever they can to help the child without putting a formalized label on it, right? I get both sides of it, but you may want that label if you want that support for your child in a classroom environment with something like an IEP, an individualized education plan. And there's also the Connors-Wells Adolescent Self-Report Scale. So let's talk about some signs and symptoms of ADHD. A child living with ADHD might daydream a lot, forget or lose things a lot, squirm or fidget, talk too much, make careless mistakes or take unnecessary risks, have a hard time resisting temptation, have trouble taking turns, have difficulty getting along with others. So one of the complicating things here is you could read this and this sounds like a small child to a certain extent. Like, how do we figure out what's appropriate and what's not appropriate? Like I said, there's some standardized scales and checklists that can give some guidance in those areas, but we need to figure out, what it's going to be based upon what's typically is appropriate for your child's age. And even that can have some variation, right? And then the younger your child, the bigger the spread is between a child that is of the same year of them as them in school, but having a very different date of birth, right? The kid that's born in July is going to be very different developmentally from the kid that was born in January when they're like 6 months old. And I'm not saying our main concerns with ADHD is with 6-month-olds, but when you're talking about like a 3, 4, or 5-year-old, like a lot of development can come, in a 12-month span. So that's a little bit of a gray area. That's kind of tricky. And that's one of the challenges with an ADHD diagnosis is what is developmentally appropriate for your child's age. That can be a tricky thing to determine, right? Because a lot of this, if you see this in a younger child, say like 3, 4 years old, it's like, yeah, well, like some of this is very developmentally appropriate for them, even an 8, 9, or 10-year-old, right? So it's not an easy thing. It's not an easy thing. Granted, as the child gets older, if you've got a 17-year-old that is acting more like a 12-year-old, then it's a little bit easier to determine, right? But obviously, we want to try and figure out what's going on as early as possible because early intervention is always best. But on the same hand, as we'll talk as we go, it's never too late. It's never too late. So ADHD types. There's different subtypes of ADHD, right? Attention deficit hyperactivity disorder, right? So there's the attention side and then there's the hyperactivity side. So predominantly inattentive presentation, it's hard for the individual to organize or finish a task, to pay attention to details, or to follow instructions or conversations. The person is easily distracted or forgets details of daily routines. Then there's the predominantly hyperactive impulsive presentation. The person fidgets and talks a lot. It's hard to sit still for long. For example, for a meal while others are doing homework. Smaller children may run, jump, or climb constantly. The individual may feel restless or has trouble with impulsivity. Someone who is impulsive may interrupt others a lot, grab things from people, or speak at inappropriate times. It is hard for the person to wait their turn or to listen to directions. A person with impulsiveness may have more accidents and injuries than others. I'm reading these longer paragraphs because this is literally what's in the DSM. And it's going to be a bit tedious, but I'd like people to know, like, pretty much what exactly is in the DSM. Granted, there's some more verbiage, there's some more discussion and things like that in the book that I'm giving you. But these are the diagnostic criteria. This is the main heart of what's in the DSM, and I think it's important for people to know what's in there. So bear with me if some of this is a little bit long-winded and repetitive. Then there's the combined presentation. So we have the inattentive presentation, so your child could be more just on the inattentive side of things and not be that hyperactive. That would be where we'd have somebody maybe that would have attention deficit disorder or ADD. The way it's laid out now in the DSM, there's ADHD and then it's broken into different subtypes. We're not using the term ADD as much as we used to, because now it's ADHD, and then which type are you? The inattentive type, the hyperactive type, or the combined type with both? To a certain extent, that's just semantics, but that's how it's in the book, so that's how we're going to go over it. Because you should know how it is in the book, and the book sometimes, it's been a process with ADHD and some other diagnoses where in the last few editions of the DSM, it's been more combining things and less specifying things with other separate diagnoses. That's just what's the route that's been taken. I don't necessarily agree or disagree with it. ADHD diagnoses, some more information. We need several inattentive or hyperactive impulsive symptoms that were present prior to the age of 12 years old. So technically, even if you're like 17, we need some kind of history where several, I'm not sure exactly what several means, but several inattentive or hyperactive impulsive symptoms were present prior to the age of 12 years old. This is going to, give us some specific numbers to look at, but I'm not sure that, if you got a 17-year-old, like how many they needed when they were 12 necessarily. Several inattentive or hyperactive impulsive symptoms are present in 2 or more settings. That's why I said it's important, right? You want to look at what's going at home and in school and maybe some other environments with friends and relatives, grandma and grandpa. The kids usually act differently around grandma and grandpa than they do with their parents, right? So multiple environments is helpful. Because what does that mean if your kid has more attention and hyperactivity issues at school than at home? Maybe we need to make changes to the school environment, right? Maybe we need a different school setting. Maybe the child has more freedom at home to move around. It's difficult. Like there's things that need to be taught. I don't envy being a teacher, especially in a public school environment, right? Because there's a curriculum that needs to be gotten through. But I would also argue that the way that kids are taught in schools, especially younger kids, is not necessarily appropriate, right? It's a little bit unrealistic to sit a 5-year-old at a desk and expect him to sit there the whole time. And I'm not saying that that's what elementary school teachers in the public school system or private school systems. I'm not saying private school is better necessarily, right? But it's not that realistic to have kids sit at a desk all day. And I know that the teachers themselves feel for the children, but there's material that needs to be covered. And it's difficult because different kids have different needs and they're going to thrive in different environments. But that's why we want to look and see if it's in multiple environments. If it's in multiple environments, then we've got a more specific ADHD issue. We've got arguably a little bit more serious difficult situation on our hands. So there needs to be clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning, right? It needs to be fairly severe issues with attention, things that are beyond their age-appropriate level. The symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder, e.g. or example, mood disorder, anxiety disorder, dissociative disorder, personality disorder, substance intoxication, or withdrawal. These are some more significant psychiatric diagnoses, right? Like schizophrenia. It's understandable, like, if you got schizophrenia and you've got some attention issues, like it may be more the schizophrenia. It's, we don't necessarily need to give you schizophrenia and ADHD. But on the same hand too, like we understand that ADHD, as we discussed earlier, 78% of the people with ADHD have something else as well, right? So this is a little bit confusing, arguably, that the symptoms do not occur exclusively during the course of I get it with schizophrenia or other psychotic disorders, but that are not better explained by another mental disorder, right? Because it talks about anxiety disorder, but anxiety can be one of the things that you have with ADHD. So gray areas, like I said, gray areas as far as the diagnosis. The symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or failure to understand tasks or instructions, right? It needs to be a little bit more specifically ADHD. But like I said, there's gray areas. And for older adolescents and adults age 17 and older, they need at least 5 symptoms. We're going to go over the different categories of symptoms for the inattentive issue and the hyperactivity side of things, right? So if it's 17 and up, they need 5 of these things to be occurring for them. Whereas if they're below 17 years old, they need 6. So inattention diagnostic criteria. 6 or more of the following symptoms have persisted for at least 6 months to a degree that is inconsistent with developmental level, like we talked about, not appropriate to their age and developmental level, and that negatively impacts directly on social and academic occupational activities. So it needs to be serious enough to where it's affecting you at school or socially with other people. So here's one of the criteria. Often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or during other activities. Often has difficulty sustaining attention in tasks or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. Often has difficulty organizing tasks and activities. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. Often loses things necessary for tasks or activities. I have that pretty bad, that last one, right? And that's part of the challenge, like I said, is that you hear these things and you're like, I've got a lot of those things. I wouldn't jump to that you have ADHD. When people come to me and they want an ADHD diagnosis, they don't have one yet for their child, and say they want it for school, right? Because they want services at school. I highly recommend that you see professionals that do those standardized checklists, right, to get that ADHD diagnosis from one of them to then get the services that you want at the school, okay? Because I think that's going to outline a little bit more clearly, do they officially have this ADHD diagnosis, right, that we need to get services at school. The work that we're doing in here that we're going to get into, my main focus is I take these behaviors into consideration, and if the child already has an ADHD diagnosis, but I want to observe them and see how they interact for myself and have a conversation with the parent and find out how they interact at home, right? And I want to look at how their brain is functioning, and that's my window into what do we need to do to help this child. Not necessarily just based on their behaviors, because multiple different areas of the brain can lead to the same behavior, right? And it may be one area or one network, which is a group of areas working together in the brain that is problematic for one child, and it may be another for a different child. But we'll get into that more later. Hyperactivity and impulsivity diagnostic criteria. Once again, you need 6 or more of these that have persisted for 6 months, at least 6 months, to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic or occupational activities. Often fidgets or taps hands or feet or squirms in a seat. Often leaves the seat in situations when remaining seated is expected, right? That could easily be a school environment. Often runs about or climbs in situations where it is inappropriate. Often unable to play or engage in leisure activities quietly. Often on the go, acting as if driven by a motor. Often talks excessively. Often blurts out an answer before a question has been completed. Often has difficulty waiting his or her turn. Right? Once again, often interrupts or intrudes on others. Depending upon the age of the child, like, it can be really tough to determine this. That's why more typically children with ADHD are diagnosed a little bit older than we see with some other neurodevelopmental issues, right? It's usually like 4, 5, 6, right? We're not typically seeing like 3-year-olds that are getting diagnosed with ADHD. So let's talk about, what do we do about this? What treatment options are out there? We'll talk about the typical ones, and then we'll talk about, what are some other things that can be done. In particular, how can we help here at Georgia Chiropractic Neurology Center? So the first line is meant to be behavior therapy, including training for parents. So with behavior therapy, it's about doing the therapy with the child and with the parents so that everybody's on the same page. Not necessarily meaning like everyone's in the room together. That usually occurs at like a later age. Usually it's more at younger ages. It's that, a therapist, a counselor, a psychiatrist or psychologist may work with the child on its own and then meet with the parents and talk about, what strategies can we use, right, to encourage positive behaviors, right? Positive reinforcement is going to be a factor in this, right? Little activities that you can do with your kids, like talking about sharing so that it can create better social interactions, different sharing games, things of this nature. When I tried to dive in deeper to like specific behavioral therapy, it was a little bit tough for me to get more information on it. Like this graphic that I have here is what the CDC provided. The CDC didn't really dive in, and I'm not saying I ended my search at the CDC and what they had to offer. But, cognitive behavioral therapy can be a factor in this. There's different types of therapy that could be utilized. But most of the time, it just is spoken of as behavior therapy. Right, so you want to talk with your psychologist or psychiatrist or counselor and find out what kind of therapy they could offer your child, because it's a broad array. It's not like there's a standardized ADHD behavior therapy training, right, that these kids go through or these parents go through. So behavior therapy training for parents is effective for managing disruptive behaviors in young children through age 12, right? The age when the child are ready for their own therapy varies, but usually by about 8 to 10 years of age. School-age children, parent training and behavior therapy with children can be very effective where used in combination. All right, and this could be used in combination with medication. But typically with younger children, you're going to want to do the behavior therapy first. That is the recommendation, is that the behavior therapy is done. And then if that's not working, then we do medication. With older children, like 8, 10, 12 years old, you may start getting into the medication earlier, and they recommend combining the two. But certainly with younger children, like 6 and below, it's supposed to be behavior therapy. And if that's not working, then medication. Right? That's the way it's supposed to work as far as what CDC recommendations are, FDA recommendations, and the recommendations that I could find. This is not the avenue that I take, so I'm not saying I'm the expert in this. I'm not a psychologist or a psychiatrist. I don't do these checklists with people, right? I refer them out, so I'm not saying I'm the expert on these things, right? But I do think it's important to know what's out there, and I'm just trying to give you the knowledge that I have, that I've been able to find in my research and over the years with working with families with children living with ADHD and other neurodevelopmental disorders. So let's look at the medication that's involved with ADHD. So this graphic's a little bit small. It talks about kind of the top 4 medications: Ritalin, Adderall, Vyvanse, and Focalin, which are the names. Which are the brand names, right? Like Adderall is an amphetamine, and Ritalin is a methylphenidate, and Vyvanse is an amphetamine, and Focalin is a methylphenidate. And those are like the top 2, methylphenidate and amphetamine. So young children may have more side effects from ADHD medications than older children, right? Hence why young children are supposed to be doing behavior therapy first. The long-term effects of ADHD medication on young children have not been well studied. So one more time, the long-term effects of ADHD medication on young children have not been well studied. I believe on older children, there's been more studies, but on young children, which are considered 6 and below, not well studied. Not well studied, the long-term effects. 2 classifications of ADHD medication. We're looking at stimulants, right, which is pretty common to use stimulants. Contains various forms of methylphenidate and amphetamine, right? Those are the main ones, like I said. Believed to increase brain levels of dopamine, a neurotransmitter associated with motivation, attention, and movement. We're going to talk about something else that has been studied that can work with dopamine as well. That may be a good alternative if that's the route that parents choose to go to medication, or supplementing the medication. And we'll talk about that. There was a little hint about it in my first slide. It involves a flower. Non-stimulants. The FDA has also approved 4 non-stimulants to treat the symptoms of ADHD. Strattera, Quellbri, Intuniv, and Capve. So Intuniv is guanfacine and clonidine is Capve. Once again, it's not in my scope prescribing medications, so I'm not the expert on medications. But these are the things that have been offered. Some SSRIs are options. Right, we're going to go in a little bit deeper here. I'm just putting these graphics up. Hopefully people can see them well. If you're interested, these are short-acting, immediate release amphetamines and methylphenidate. So you've got short-acting, immediate release, where you're going to get the medication to your system faster, but it's not going to last as long. The duration of these is anywhere from 3 to 5 hours with the methylphenidate to 4 to 8 hours with the amphetamine. And part of the struggle can be like, you got to take more medication to keep the effects going, because it's not, ADHD medication is not like taking medications for an infection. Right? It's not like you take the pills for 7 days and then the infection is gone. It's not like antibiotics. When you stop taking the ADHD medication, then you stop getting the effects. And you could be on ADHD medication for years. It's not like it counterbalances your system and then your system learns to adapt and then you can gradually get off the medication. If the only route that you're going is medication, like, you may be on this for the rest of your life. As your child matures and develops, their brain is probably going to get better at focus and attention, right, comparatively, right? And that's just all children. So some people may get off the medication later in life. I'm not saying no one does, right? But there's often times where when you're on this medication, you're just on this medication, right? Unless you take other means. Then there's intermediate and long-acting stimulant medication, which are, once again, methylphenidate and amphetamines. We're talking more like 10 hours, right, up to 12 hours, sometimes 7, right? There's big ranges here. I'm not going to read all these to everyone. But then, you might be able to get further through the day. Your child may be able to get through the full school day or most of their day, right, with these stimulant medications. And then, as I said, there's selective these are selective norepinephrine reuptake inhibitors, because norepinephrine, right, which is one of the hormones in the body that is also involved with ADHD, right? Alpha-2 adrenergic agonists, and then non-repiphine it's dopamine reuptake inhibitors. So it's meant to hold on to the dopamine for longer, and then some tricyclics. So various medications, basically non-stimulants, and then the last two categories are antidepressants, basically. So antidepressants may have an effect on ADHD. There's been some studies with that, right? So what else is there for ADHD in addition to the medication? Like I said, I didn't go into the side effects with the medication. That's something you should talk to your doctor about, but there are side effects with the medication. Hence why some parents don't want their children on medication. But some parents reach a breaking point where like maybe they've tried the behavioral therapy aspect of it and it's just not working. So what the heck are you going to do, right? What else is there that's out there? Well, just know that there are other things out there if you choose not to go the medication route, or the medication route just isn't enough. And honestly, a lot of children don't do well on the medication. Some do and some don't. It's like any other medication. It's, for some people it works and some people it doesn't. Some people are allergic to it, some people are not. So what else is there for ADHD? We got the rice on the table here because saffron, that's the flower. It's the most expensive spice in the world, saffron. It's, like I said, it comes from a flower. But it can do some pretty cool stuff. We're going to talk about it. There isn't a huge research base on it, but the concerns with it and the negative side effects are pretty small with saffron, right? Pretty small. You basically take saffron extract, which can come in a pill form, like a vitamin, right? And you can get it pretty readily. And then naturally, we're Georgia Chiropractic Neurology Center. We can help with ADHD. So there's also chiropractic neurology as well. And we're going to talk about what we can do to help. But I thought saffron was really cool, so I wanted to talk about that briefly, right? Before we get into what we can do with neuro rehab to help, to get things back on track, to have lasting effects. The most common prescribed drug for treatment of ADHD is methylphenidate, which we had discussed before. And it is believed that it can improve cognitive function through a dopaminergic effect. It works with this chemical called dopamine, right? Everybody talks about dopamine hits these days, right? You want these little dopamine hits, so you're on TikTok all day and you're addicted, right? You just want these little hits of dopamine, right? That's what people are talking about these days. Dopamine does a lot of different things, and it's one of the things that has an effect on ADHD. That's why some people have concerns about technology with children, because there is some truth to, being paranoid about being on social media all day because you're getting these little dopamine hits. Like, there is some truth to that. It's difficult because a lot of the time, especially with TikTok, it's geared towards inattention. It's geared towards very fast little clips, right? It's not Game of Thrones. Not that I'm saying your kids should watch Game of Thrones. But, it's not The Little Mermaid where it's like this story that lasts for like an hour and a half where if they want to get the full thing, like they got to sit there and they got to pay attention. It's these little snippets, right? So it can drive that dopamine in a negative way when we're practicing short spans of attention with things like TikTok. And it's not just TikTok, right? It's other social media as well. But let's really hammer home here, like I'm trying to do, that dopamine is involved, right? And that's where it comes in with the methylphenidate. I talked about a lot of children. I think 30% of children with ADHD that don't respond to methylphenidate is kind of a big deal. And they may not respond to the other medications, right? It may not be enough. Or maybe you don't want to go that route. So saffron has several psychoactive properties and acts on NMDA, GABA receptors, facilitating dopamine, serotonin, and noradrenaline secretion, right? Remember we had those noradrenaline reuptake, right? Meaning that we don't want to get rid of the noradrenaline. We want it to hang out for a while because that could have a positive effect on the brain as far as ADHD. Well, saffron can help you secrete noradrenaline, right? It can help facilitate dopamine and then also serotonin, right? Which is often associated with positive feelings, but there's other aspects of serotonin as well. But these chemicals that are involved with ADHD that the medication are meant to impact, with the preliminary research that's been done, granted it's some small studies, but saffron may provide benefits that are pretty similar. Both dopamine and noradrenaline are the core neurotransmitters associated with ADHD, right? So, saffron and ADHD. The present pilot study, I looked at a few different studies, and there was one that was more recent that actually talked about some of the ones that were done in the past. But it was a pilot study that compared the efficacy or the effectiveness of saffron, which is 30 milligrams per day. Some of the other studies I saw, depending upon the weight of the child, they'd either give them 20 milligrams or 30 milligrams a day. But in this study, it was 30 milligrams a day. And I'm trying to remember, but I think in the study, the mean age, or like the average age of the child in the study was 11 years old. Right? Some were older, some were like 17 years old, but the average age was 11 years old for the children that were in this study. But anyway, the present pilot study compares the efficacy of saffron, 30 milligrams per day, and methylphenidate in children and adolescents diagnosed with ADHD. The most relevant finding is that both treatments showed statistically significant improvements in both core ADHD symptoms and executive function, meaning that they performed pretty similarly, at least in these studies. And like I said, I'm not saying these are the end-all be-all, but there's some preliminary research with saffron that looks pretty freaking good. And there's a pronounced difference, a pronounced difference was found in the saffron arm in the sense that the parents of the children treated with saffron reported a pronounced improvement in the time to fall asleep. One of the challenges with ADHD can also be sleep dysregulation, where kids will wake up in the middle of the night. Sometimes they may have trouble falling asleep, but sleep does seem to be one of these 78% of things that is a co-condition that goes with ADHD, meaning that you have ADHD and you have issues with sleep, whether it's falling asleep, staying asleep. But with this, they found with saffron that it helped get people to fall asleep, which is pretty cool. So I think saffron is a pretty neat thing that should be researched more. It's a bit of a challenge because I don't know, who's going to be able to fund the studies for saffron, because it's not something that it's something that anybody can make. So if one company invests tremendous amounts of money in it, another company could just make some saffron and they reap the benefits of that study as well. So it makes it pretty difficult. But I definitely think that there should be more research on saffron and ADHD, because like I said, with these studies, they saw similar effects of phenidate. Pretty awesome. So let's talk about what we can do at Georgia Chiropractic Neurology Center to help ADHD. So we need to understand the areas of the brain that are involved, and then the approach that we're going to take is we're going to investigate the functionality of those areas or networks. What you're seeing in this little graphic that's on this slide is some networks, some communication between different areas of the brain, right, that are involved with ADHD typically. Honestly, if you look through the literature, there's a lot more detail than this. There's a lot more areas of the brain, right? There's a lot that goes with ADHD. Typically, when we're talking about ADHD, we're thinking the frontal lobes, and that's often what's discussed, and there's a lot of truth to that. But there's other areas of the brain, as we're going to get into in this slide, that are involved as well. And I'm just letting you know, like, there's more in addition to this slide. I just wanted to keep it relatively simple and hit some of the high points. But what they've noticed in some studies with ADHD is that there's reduced total brain volume and volume of some brain structures. There's cortical differences when they're comparing ADHD brains to other people's brains. There may be delayed cortical maturation in children and adolescents, meaning that they just are maturing a little bit slower. Okay? Reduced cortical thickness in adults, that goes to that total brain volume, like we talked about. Regions of the brain that have been implicated in ADHD correspond to brain networks, right? Areas of the brain working together, involving frontal regions or supporting executive function and attention, right? As in child ADHD, abnormalities in adults appear to encompass the prefrontal cortex and its connections to the striatum, with the addition of networks involving the cerebellum, the back bottom part of the brain, right, which is involved with coordinating movements, coordinating thoughts, muscle tone, balance, and a few other things, as we'll discuss further, and the parietal cortex. So we're going to talk about these three big areas of the brain. We're going to talk about the frontal lobe, we're going to talk about the cerebellum, and we're going to talk about the parietal cortex, right? These are some of the major players that can be involved with ADHD. The one that gets the most attention typically is the frontal lobe. And then there's this area called the basal ganglia, which is kind of indirectly mentioned here, that is involved, that is regulated by the frontal lobe. And the basal ganglia starts and stops thoughts, emotions, and movements. So you can see where starting and stopping thoughts may go with an ADHD, right? Hence starting and stopping movements, right? Because that can be part of the hyperactivity component. But the frontal lobe is going to help regulate that basal ganglia. So we're going to focus more on the frontal lobe, the frontal lobe, the parietal lobe, and the cerebellum. So, like I said, those are the areas that we're going to focus on. All right, so the frontal lobe. We got a picture of it here. It's the front part of the brain, the occipital lobe in the back that you can see there. That is the back, like I said. Then there's the temporal lobe, the parietal lobe. And then that little thing hanging off the bottom that's still wrinkly, that's your cerebellum. And then that little stalk coming out of the bottom, that is your brainstem, which then turns into your spinal cord. So one of the ways you can look at the frontal lobe is it's the boss. It's involved with executive function. It's involved with cognition. It's involved with regulating emotions. It's involved with generating movements. It's involved with a lot of things, okay? It's involved with planning and goal setting, motivation, attention, right? Attention's a big one for somebody that has attention deficit hyperactivity disorder. So, within the frontal lobe is the motor cortex, and that's the little thing, if you look at the far right picture, that's kind of painted red. And then this is meant to be a representation of that motor cortex. So those are different areas of the brain, have different amounts of real estate dedicated to them for movement, right? There's a lot more real estate in the brain. At least this is one way to look at it. We need highly tuned function of our hands, less so our feet, which is why our feet are represented smaller on there. A lot with our face, and in particular our mouth. Our tongue is pretty big on there. Our tongue is like as big as our foot, and that's not the case in real life, right? But we do complex things with our tongue, such as speaking. Same thing with our face, right? And then we show emotions to other people. We kind of take that for granted to a certain extent, but there's a lot of complex things that are going on with people's facial features when they have a well-functioning brain. That's part of the reason why when people start to decline in their mental capacity, people with Alzheimer's, dementia, or types of cognitive impairment, they tend to have what's called a flatter affect, where they just don't show as much emotion. That's a complex thing, to be able to show emotion to other people so that it can be interpreted, so that we can better know what other people are thinking, so that we can connect with them mentally, emotionally, right? And eventually in many other ways. So the motor cortex is located in the frontal lobe. Body parts in the frontal lobe, located in the frontal lobe. Body parts that make up the finest movements take up the most space, as I said. The right frontal lobe has a map of the left side of the body, and the left frontal lobe, has a map of the right side of the body. And there's some overlap between sides. And that's meant for volitional movements, right? Volitional movements and functions. It's not quite that simple, but that's a pretty good way to look at it, right? So we could look at different movements on the right side of your child's brain and be thinking left frontal lobe, or left side of the brain, and right frontal lobe, depending upon their movements on the left. So we might look at fine motor movement, right? Which is with a finger tap. And maybe there's a different side to side where, oh, this is kind of difficult, right? Whereas it's a lot easier, it's a lot faster on this side, okay? So that can let us know, hey, one frontal lobe versus the other, which one do we want to work with? And once again, it's not that simple. It's an integrated network, because guess what? The frontal lobe is going to work with the basal ganglia, it's going to work with the brainstem, it's going to work with the cerebellum, it's going to work with that network, right? And one player in that network or multiple players in that network could be having issues that lead to focus and attention issues. But that's the beauty. When we can figure out which areas of the brain are struggling, then we can exercise those areas of the brain to make them stronger. We can exercise those networks and get better focus and attention that way, and help grow and develop that brain that is lagging in growth and development. We also look at gait. I'm just giving you a few things that we look at that make us think frontal lobe here at Georgia Chiropractic Neurology Center. So with gait, we're going to look at how people's arms swing, their movements in general, and then we're going to give them a big frontal lobe task, like giving them a multitasking activity where they're walking and they have to, say, subtract 100 by 5s or 7s, depending upon the age level. We maybe have them recite the alphabet backwards. We're going to make it age appropriate to the child, but if I've got like a 15-year-old, like I'm probably going to give them the months of the year and tell them to repeat them back to me in reverse order while I watch them walk. And some of them may freeze, right? Or their gait slows and their arms don't swing as much. Their frontal lobe is getting overly taxed and they're not able to maintain those reflexive movements, and it lets me know, hey, we want to work on that frontal lobe to get it working better. Also, saccadic eye movement. What saccadic eye movement is fast eye movements. So I may have some puppets or I may have some toys in each hand, and I'm like, hey, look at the car. Look over here. Look over here. Our eyes are going to jump to these different targets. If it's an older kid, or a teenager, I'm going to be like, all right, look here, and then you're going to look at my thumb that wiggles. And then we're going to look at how well their eyes get to that target. We're going to look at the speed that they move at. We're going to look at the delay, their reaction time, or what's called their latency, from when I flick my thumb to when their eye moves. And do they get there in one fluid movement, or does it take them a couple steps? Do they overshoot and come back? Your frontal lobes are heavily involved with these fast eye movements called saccades, as is your brainstem, as is that basal ganglia that I spoke about. And certain aspects of it, same thing with your cerebellum, okay, as far as the accuracy of them. So there's multiple areas in this network that we're testing by looking at eye movement. Here's one of the other things with kids with these saccades or fast eye movements. When a child reads a book, it's a series of fast eye movements to get across the page. You may think, no, it's you like see their eyes sliding across the page, so they're really tracking or pursuing. But pursuits don't work that way. We need a moving target to pursue a target. It's actually little jumping movements of the eyes. So if we see that kids can't focus and attend on a target, right? Or they can't jump their eyes accurately, they're overshooting, then they're not going to be able to read very well. I had one patient, let's talk about our first patient story. We'll call him John. John was a teenager and he had a lot of trouble navigating his environment, like just getting around school, okay? Which is challenging for someone that's a teenager because you're expected to like just get yourself around school, and that was a big challenge for him. He had a lot of trouble reading. He's a smart kid. Well, he's not a kid anymore, but he's a smart guy, and he's extremely outgoing, and he's fun to work with and hang around with, quite honestly. But he's a great person. He's a smart guy. But when I got to work with him when he was well into his teenage years, he couldn't keep his eyes on a target. He couldn't hold his eyes still on a target. He couldn't follow my thumb when I slid it, and he sure as heck couldn't jump his eyes accurately back and forth. So this kid stood like no chance of being able to read effectively because his eyes didn't move effectively. So I looked at it and I was like, I could understand why this kid is struggling with reading, right? But he can learn really well when you talk through things with him. His parents were having to like read his assignments to him, right? And then he could do it. He could understand it, right? But he couldn't keep his eyes on targets. So one of the big things we did for him was that we did eye movement training with him. So did he have an ADHD diagnosis? He could, because if you can't keep your eyes on anything, as a little kid, you're like all over the place, right? Because you're not focusing and attending your eyes to any one thing. Fortunately, one of our docs, Dr. Owens right now, is working with a little boy who's, I don't know his exact age because he's not my patient, but he's probably about 3 or 4 years old. And one of the big things with him is like, you could look at this kid and you'd be like, I could see where this kid could be diagnosed with ADHD, right? He's running around, right? And he has trouble focusing and attending to things, but he couldn't focus his eyes on a target. And she's been playing games with him just trying to get him to focus on different things. She's doing a lot of other stuff with him, but one of the big things that she's trying to do is just get his attention and train his eyes how to stay on targets. And he's calming down more. He's interacting and playing with others more. He's playing independently more. He's able to pull himself out of out of tantrums, which is normal for a 3-year-old. But his were more intense, and they're becoming less intense. His life is changing because his eyes can move better, in addition to the other things that she's doing with him, right? But she's, at the end of the day, she's getting his brain to work better so that he can process his world and understand it. And then he knows where he fits in it, and it's not as scary of a place. And honestly, it's a lot more fun place to live when you understand where you are in your world, because you can see and feel things accurately. And that's what that kid can do, and that's what this kid, John, can do now, right? He can see and process things more appropriately, so life is easier for him. He can get around the grocery store without having to be right next to somebody, right? That's a big thing. That's life-changing, right? We take it for granted, but that's a big thing for him. So let's talk about the parietal lobe. I talked about processing your environment in those patient examples, right? So the parietal lobe creates and contains the somatosensory map. So what the heck does that mean? It processes sensory information from our environment. I talked about the motor strip, right? And that was about generating movement. So it was a map of our body so that we can move our body in our world. We have a sensory map in our body so that we know where the world is relative to us. And what is the condition of the world? Is it safe? Is it not safe? Is it fun? Is it serious? How should we be interpreting this situation? That can be a big challenge for a child with ADHD. That's one of the diagnostic criteria. Are they acting appropriately in the appropriate situation? Are they climbing on things when they're not supposed to be climbing on things, right? Your parietal lobe, sensory processing of your environment, can be involved with this. Dr. Wright and I have been working with a young man where he's very sensitive to touch, where he gets super ticklish, right? So one of the things that Dr. Wright has worked on with him is that he's just trying to get it where he can just put his hand on his back, right? Without him getting all squirmy. And that's, if you're sitting in a seat and it's not the best texture for you, you might get squirmy in your seat, or it could be like your shirt. And that's going to look like impulsivity and hyperactivity. But we want to make sure that this somatosensory cortex, which lives in the parietal lobe, is accurate, right? Are these maps, are these representations that we see on here accurate, or is your brain perceiving the environment different? So located in the parietal lobe, body parts with the most sensory receptors take up the most space, just like in the motor strip. The most motor function took up the biggest part of the strip. The right parietal lobe has a map of the left side of the body, and the left parietal lobe has a map of the right side of the body for the most part. It's a good generalized way to look at it, right? So if we do graphesthesia, where we draw letters on one hand, and somebody can't figure out what those letters are, I draw a B and then a C and a D, and they're like, I don't know what those were on the left, but they can feel it on the right. And then maybe we check it on the feet and it's the same thing, or we check it on somewhere on their arm and they really can't feel it on the left side of their body. Well, then that right parietal lobe in the brain is not processing things appropriately. And we want to do exercises for that area of the brain. So what could that be? That could be having their eyes open and drawing so that they can use their vision to remap, right? So watch me draw the letter A. Okay. I can see it and feel it now at the same time. Or maybe it doesn't work well on your hand, but it works well on your arm. So then we do it on your arm and we do it lower and lower and lower until we reach your hand. Or on your hand and go up. It depends on the person. There's also toe localization. Can we touch a toe and the person tell us which toe they're touching, right? Can they do that accurately? That's a test of parietal lobe function as well. And then there's the cerebellum, that helps coordinate movements and thoughts. That's the back bottom part of the brain, the wrinkly part. That it has its own maps in there, and you can see those maps in the very lower right with those little, it kind of looks like a body, but it almost looks like a little frog, but that's a representation of the body as far as coordinating movements and coordinating thoughts. helps create posture tone, right? Muscle tone for good posture. And it has, like I said, maps of our body as well. The right cerebellum, for the most part, a good generalization. I'm not saying this is exclusively how it works, but for the most part, the right cerebellum works with the right side of the body, and the left cerebellum, works with the left side of the body. So it's same side. Frontal lobe and parietal lobe, opposite side of the body. Cerebellum, same side of the body. Decent way to look at it. Assessing for cerebellum function. Right? We're going to compare this flip-flopping movement, which, believe it or not, has a fair level of complexity, and see the speed, the amplitude. Is it fish flopping all over the place, or is it more fluid like this side? Is it slower on this side and faster on this side? So we're looking at speed, amplitude, fluidity, things of that nature, right? And then finger, nose, finger. So I'll hold my finger out in front of them. So this is the doctor's finger. I'm the patient. This is the patient's nose. This is the patient's finger. And they go back and forth between the doctor's finger. And then I move it around, right? And see how accurate they can be with it. If there's a little tremor at the end, it can give me some good information about how well that cerebellum is working, but also how I'm not doing these individual tests and thinking that's just the cerebellum, that's just the parietal lobe, or that's just the frontal lobe. Because if you understand the networks and how they interact, you can do this cerebellar test and see frontal lobe aspects to it, or basal ganglia aspects to it, right? Or even parietal lobe aspects to it to a certain extent. There's also heel to shin, where we drag the heel down the knee like you see in this picture, and we look for how fluid and how far they can go with that foot. So some different assessments of cerebellum function. Honestly, part of the frontal lobe, parietal lobe, and cerebellum is just watching people walk. Like I said, I talked about it with frontal lobe, but there's different gaits. There's like people get real wide base, meaning their legs are really far apart if they're having issues with their cerebellum. So we're going to look at how kids walk and interact. So what do we do with all this information? So we say we've got a kid where we want to work with the integration of the network with their left cerebellum and their right frontal lobe, and they've got some issues maybe with their right parietal cortex. So like, what therapies could we do to address those? So for the parietal lobe, we could do we could do what's called point localization, where I touch a spot and then they have to touch the same spot. It's also a test, right? With their eyes closed, I touch that spot. Can they get to the same spot, or are they like way off, right? This young man that Dr. Wright and I were working with, Dr. Wright was working with him at one point, and he checked his point localization on his arm. And Dr. Wright would touch here, and correct me if I'm wrong, and I'm not exactly, but he would not even touch his arm and think he was there. Correct. Yes. So I don't know if it was that far necessarily, but he was not making physical contact with his arm. Do you think he knew where that arm was in space? So he's not really processing that input. He can do it better now because they remapped that. If he doesn't know where his body is in space, do you think he's going to be able to control it? Or do you think his brain's going to want constant feedback as to where his body is in space, and then it's going to be really hard for him to sit still because he doesn't know where his body is in the world? I think it's going to be really hard for him to sit still because I've seen it, where if you know where your body better is in space, you're going to be able to control it better, and it's like, oh, yeah, I can hold this thing still, because your brain needs constant feedback from its environment to stay active. And if it's not getting the activation that it needs, it's going to find another way to get the activation, right? It's going to crave sensory input. You could do vibration therapy, where you vibrate on one side of the body to go up, say, to the left cerebellum, and then to the other side, parietal lobe, on the left side of the body. For the frontal lobe, I talked about how we use those fast eye movements as a diagnostic tool. Well, it's a therapy as well, because it's going to activate your frontal lobe. So let's say like you always fall short. You always fall short to the right. Well, then I might shorten the distance of your eye movements and do it at a distance that you can do it, and then gradually spread it out. And then all of a sudden you're getting more accurate. And do you see where that could be valuable in, say, reading? Right? If you're constantly falling short of your target when you're reading, you're like, oh crap, I got to go back. and not even necessarily consciously. Although that might be the person that gets lost in the paragraph because their eyes just aren't accurately getting across the page. But if we get a better accuracy of those fast eye movements, right, it doesn't take you 2 steps to get from point A to point B, it takes you 1 instead of 2. How much faster are you going to read? Probably a lot, okay? Double tasking activities. So we may have people, we've done it a lot with kids, Dr. Wright and I. We have kids walk backwards, right? Doing big exaggerated arm and leg movements in the same pattern that you'd walk forward with opposite side arm and opposite side leg, moving together. But we have them walk backwards, which that's a difficult thing to do, or we might have them walk forwards and we give them multiple things to do. We ask them math questions while they're doing that. So they're having to move their body, figure out where it is in space. This is a little bit trickier than walking forward and going cross body like this, and then we're giving them math problems on top of it. And it's strengthening that frontal lobe, which is involved also with focus and attention. Cerebellum, we could do complex movement patterns with their arm and leg on the right side of their body to affect their right cerebellum and then in turn their left frontal lobe. Interactive metronome, that's the picture that you see on here. This is a really powerful tool, and there's been a fair bit of research with this with ADHD. So it's about timing of firing of different areas of the brain. So there's a metronome. A metronome keeps time. You know, you might set it to like 96 beats per minute, and then you're going to create your rap song, right? It's at 96 beats per minute. Or you're playing piano, and it's going to keep time for you while you're playing piano, right? DJs live and die by beats per minute. Computers can probably do it now, but I'd argue you're a better DJ if you can do it without entirely relying on the computer. But with the interactive metronome, it's going to give you feedback because you're going to clap along. Am I at 54 beats per minute? This kid's looking at a screen where there's a game on there, but the game is really training him to clap with good timing. We want timing of movement, involves timing of firing of different areas of the brain, and there's been a fair bit of research with this device with many things, but in particular with focus and attention, executive functioning with ADHD. So it's a big tool that we use honestly with a lot of our patients, but especially with kids with attention deficit issues. But yeah, timing, attention, and working memory. All right, we're at that point of the evening where we can do some questions if anybody has some questions.
Yeah, so we had a couple. So the first question is...
I can't see it on my screen. That's weird. Sorry.
What is the connection, if any, with the symptoms of ADD or ADHD and emotional deficits?
With the symptoms of ADHD and emotional deficiencies. Well, so we talked about, you know, and I talked about how we don't want to make it all about the frontal lobe with ADHD, but it is a big player with it. If you're having focus and attention issues, you're having issues with the functionality of your frontal lobe, I talked about one of the things that it's involved with is it works with that basal ganglia with starting and stopping thought patterns, starting and stopping emotions, right? And your frontal lobe is going to have an effect on the emotional areas of your brain, helping to regulate that, right? They've seen patients that have had strokes or frontal lobe injuries, and then their emotional regulation is just all over the place, right? So if you're having areas of the brain that could lead to attention deficit issues, you're probably having issues with areas and networks in the brain that are involving with not only keeping attention in check and focus in check and movement, right, and your activity, meaning not hyperactivity, but appropriate levels of activity. If you're having trouble keeping that in check, you're probably having trouble keeping your emotions in check. And then was there a second one with that? Since we are basically electric beings, would vibration frequency therapy help lessen the symptoms of ADHD? Sorry, vibrational frequency therapy. I would argue yes, right? It's been interesting. We've seen different frequencies of vibration. And we may not be talking about the exact same therapy, but we've seen different frequencies of vibration influence different things for different people. Like we've seen different frequencies of vibration help attenuate people's tremors, but one frequency doesn't work. If we change up the frequency, because we'll use like a vibration tool, if we change up the frequency, it may work better for somebody. So different vibrational frequencies I could see helping, right? Could be a positive thing for people, right? And there's you can go deep on vibrational frequencies as well, in addition to just, you know, having someone stand on a vibration plate or taking a vibration tool and running up and down one side of the body. But we find that to be powerful as well. Was there any others that anybody had? And I'm sorry if I missed these as I was going. I was trying to watch, but my chat wasn't open appropriately in my computer up here. Well, while we're waiting to see if anybody else comes through with a question, I just want to take a moment to recap some things. I don't have an official recap thing on here, but we talked tonight about the options for ADHD. We need to understand, well, let's answer the question. Let's answer the question. Is it psychological or is it neurological? And I think I already answered it, but I'd say yes. Yes. Is it psychological or neurological? Yes. It's both, right? But I think that's going to be an ongoing question because I think there's aspects of both. And it's a complex, convoluted thing. That's why, you know, we like to co-manage patients too, because there can be some psychological aspects to this that are best processed by how we're affecting the brain, right? And that can help people release things psychologically. And that's, we're so very fortunate to have Dr. Bouth because, you know, we all here can influence people's psychology by getting their brain working better. But Dr. Bouth just has some extensive expertise in working with people that have some more psychological symptomatology, such as attention and focus issues, obsessive thoughts, depression, anxiety. But it also can involve, you know, obviously co-managing with like a psychologist or a counselor or somebody of that nature, because talking through things and doing some of that behavioral therapy can be beneficial. Does childhood ADHD, sorry, there's a heart in the way, develop into adult ADHD? I'd say oftentimes yes. At one point in the past, like, it was thought that adult ADHD wasn't really a thing. But, you know, kudos, I would say, to the new DSM version. It talks about how adults need 5 of those symptoms as opposed to children needing 6. So they're acknowledging that it exists. It exists in adults. So yes, it can definitely lead into adulthood. You know, some of those people on those medications, they take them as a child and they're still taking them as an adult, right? Because they need to function in their day. But just know that at any age level, like we see adults and we see children with attention issues, and we can improve their focus and their attention by getting their brain working better. Those networks in the brain that are involved with focus and attention, and sometimes they present with those things that are in the checklist, and that's kind of where the gray area comes in. You know, like this kid, John, that I talked about. John couldn't focus his eyes on things. It'd be easy to slap an ADHD diagnosis on him, but for him, I think it was more about how his brain was processing the world, how his eyes were moving in the world. There was like strong neurological components to this that was leading to these behavioral difficulties for him. I don't think he was what would be a stereotypical ADHD presentation, but he could easily have that diagnosis, and he needed his brain working better. One other patient case that I didn't get a chance to talk to about yet was this little boy that Dr. Wright and I worked with on one of my trips to Pennsylvania, working with people in the Mennonite and Amish community. I see a lot of children in the Mennonite and Amish community that have different neurodevelopmental challenges, and a lot of them have focus and attention issues. I work a lot with the children that they've adopted. I'm not saying that they have more neurodevelopmental issues in their community than we do in the broader community in the world. I've just developed a relationship with them, so I see a lot of their children. But anyway, there was this little boy, we'll call him Dan. Dan was how old is Dan? He's probably about 5 or 6 right now. His parents were trying to get him ready to go into kindergarten, and he just couldn't sit still and focus and attend for more than like a minute or two. And it was great because he had one-on-one time with his aunt, and his aunt was really good about just trying to teach him letters and just trying to get him ready for school in general. But he, once again, I'm not saying it's all about the eyes, but he couldn't track things. He couldn't keep his eyes focused on a target. He was much like that kid John that I was talking about, who was like in his teenage years. But luckily we'll call him Dan, we caught him when he was like 4 or 5 years old, which is huge because like this kid is very different now from where he was before. He can sit for like 15, 20 minutes, work with his aunt. He's well on his way to being able to enter into school with the rest of the kids and being able to focus and attend. And it's very important that we know that Dan is highly, highly intelligent. But he was trapped, right, in the limitations that he had as far as how he could function in his world. But just from working with him and interacting with him, he picks up on things extremely quickly for his age. Extremely quickly for his age. So he's very sharp with numbers and counting, right? One of the other things that Dr. Wright actually picked up on was hand position with him. So how did it go again, Dr. Wright? I think you were like this, right? Yeah. And he couldn't do the same thing. He took like another finger and was like wrapping it around and just like, Dr. Wright was like, do this for me. And he couldn't mirror that. He looked at it and he couldn't position his body in space to be able to figure out how to do that back to Dr. Wright. So he didn't know where his body was in the world, right? So he's not gonna be able to keep it still in the world. He's not gonna be able to sit. He's not gonna be able to focus. He's not gonna be able to attend. But we helped to get his brain functioning better, to remap his body and his brain's awareness of it, so that he knew where he was in the world. So then the world was a less scary place, though the world was a more interesting place, and the world was a place that he could focus and attend to, because he knew where he was in the world, and he knew where the world was relative to him, and he could see and track with his eyes what was going on in the world. Because otherwise, it's just this spinning mess that's around him, because he can't keep his eyes focused on anything, and he can't really feel the world around him very well. So he's just like all over the place, right? And he's much more focused, much more age appropriate. And it's tough because it's like that fine line with the kid. Like you could observe the kid and be like, yeah, he's just, he's hyperactive and he can't sit still. And the truth is like, no, he can't keep his eyes on a target and he doesn't know where his body is in space. And when you get his brain working better to be able to do those things, he's pretty focused. His intelligence shines through and he's better meeting his potential. We want to help people better meet their potential. I don't see any other questions coming through, so I'll probably wrap this up. But I put a slide up. If you know anybody that is living with attention deficit issues, maybe they have a diagnosis, maybe they don't, right? Maybe it's a kid that doesn't really fit in a box, or maybe it's an adult that doesn't really fit in a box, but they know that they're struggling to focus and attend to things. There may be some hyperactivity in there on the childhood side of things. We will do a consultation. We'll take at least 30 minutes with you and sit down and talk and figure out, what have you done, what's worked, what hasn't worked. We want to know what your goals are. And then we want to have the opportunity, if we think you're a good candidate for our care, to work with you so that your brain can function better, or your child's brain can function better, so that they can hit their goals, they can reach their potential, right? They can be who they're meant to be because their brain understands the world better, right? And it's more than just a checklist. It's more than just a checklist. And we're going to go deeper than that. Maybe you've gone the checklist route and it's only gotten you so far, or maybe you haven't even gone there yet. But we'd love to have the opportunity to talk with you, to find out what you've done and what could help you. So thank you everyone for your time this evening. Thank you to everybody that asked some questions. And I'm sorry to everyone else that I talked so much and maybe didn't leave room for as many questions along the way. And please share this. We'll be releasing this in about a week, but please share this with anyone that you think would be interested, because there's hope out there. There's definitely things that can be done, and it's never too late. I know I'm trying to wrap things up, but I guess I'll tell one more story. So when I was going through school, I may have told this story before, and I apologize if that's the case, but it was one of the first case studies that I got to observe with Dr. Ellis. So when I was a student working with Dr. Ellis, I got to observe this patient, and they were 30 years old at the time, right? It was somebody that was going through Life University, through the chiropractic school, trying to get through the program, and they were having issues with not necessarily focus and attention, but certainly with reading and just staying focused with reading. You know, it's one of those people that they'd read through the page and they get lost in the page. And it's not to say that they were intelligent, but you know, they just had to work harder than most people. Had to read things over and over and over and over again to understand the material, to be able to get through school and pass the tests, you know, and do well. So Dr. Ellis did an exam on this person, and then one of the big things that he did with this patient is he did a lot of interactive metronome with them. And then fortunately at Life University, there was a metronome there that they could use, so they're doing metronome there. And then he noticed too that one of his inner ear processing reflexes, when he rotated him in the chair, we didn't talk about that tonight, but I've kind of talked about that when I've talked about more dizziness. But this person didn't even have dizziness. They had inner ear processing issues that wasn't giving feedback to their brain. And by doing some chair rotations and watching some stripes go by that would mimic rotation, he was able to kick that reflex back in for this patient. So that and some myofascial work and that interactive metronome that does really good things for people. So this person was like it was 30 years old, early 30s. Their reading comprehension improved. And they wound up getting awards at Life University for scientific exploration. You know, they basically got the nerd award. They basically got the nerd award at school for being, you know, a bookworm, which for the person that spent most of their life struggling to read all through school, you know, from kindergarten on up and never really having a formal diagnosis, like this is a big deal for a 30-year-old. So that's why I say like it's never too late, you know, to get this help, to get this kind of care. The patient that he treated was me. That story is my story. So it was life-changing for me that at 30 years old, my reading comprehension improved. And now I get to work with this man every day. So thank you, everybody, for your time and your attention. And like I said, if you have the opportunity, I would definitely recommend doing a complimentary consult for us, because we definitely have skin in the game. Myself in particular, but honestly, everybody that works here, we all have skin in the game. We just want people to get better. So feel free to reach out, and I hope everyone has a good night. And thank you for attending, especially everybody that stayed to the very end, even though I almost ended this like 3 different times. So.